really helping break down the scientific information or clinical diagnosis for patients, and then walking them through what that diagnosis means, right? What potential implications could be for passing this on. But working towards getting a genetic diagnosis could help provide that more specific information. That's a lot of very technical, right? But there's emotion behind each one of those conversations. So it's also, and I think about that really, it's a conversation with patients of understanding where they're at in their diagnostic journey. How can we best support them in understanding, in their understanding of their diagnosis and what is the most helpful next step? And maybe that is genetics, and maybe it's not, right? Maybe there's some other way for us to be helpful, and at some point we'll come back to genetic testing.
You're listening to Inside Out, a podcast about living well with low vision. Maybe you're feeling confused, scared, isolated, or disheartened about a recent vision loss diagnosis. Or maybe you've been managing your vision loss for a while, and now you want to hear from others about how to continue growing and thriving. Inside Out is your supportive space to find healthy and impactful tools to build and maintain a truly rich and gratifying life with low or no vision. I'm Matthew Reeves. I'm a legally blind psychotherapist and rehabilitation counselor. I specialize in helping people adjust to disability through my practice, Integral Mental Health Services in Atlanta, Georgia. I'm really glad you're listening. Please subscribe so you don't miss an episode, and let others in the low vision community know about the podcast so the word can spread to those who might find it helpful. And now, on with today's discussion. In this episode, we're joined by three expert genetic counselors, Rebecca Clark, Emily Place, and Taylor Sabato, to demystify the evolving field of ophthalmic genetics. While receiving a genetic vision loss diagnosis can feel isolating, these professionals serve as a compassionate front door to the low vision community, offering much more than just DNA analysis. We'll explore how genetic testing can provide clarity on prognosis, inform family planning, and open doors to cutting-edge clinical trials. Join us as we discuss how a genetic diagnosis can shift the journey from a place of uncertainty to one of empowerment. This is a real treat because we have not one, not two, but three genetic counselors to talk about this really interesting area of healthcare. It's one that I have very little experience with. I had one genetic counseling session in my life, and it was a long time ago, and I don't really remember it very well. But it's becoming more and more relevant as genetics becomes a more sophisticated and advanced science. So I'm really thrilled to have the three of you here to talk about it today. And before we start, I should mention for the audience, like, we're well aware that not all vision impairments are genetic. So this isn't specifically relevant for everybody who might have a vision impairment, but it is very prevalent for vision impairments to be genetic conditions. I have no idea what the statistics are. Maybe that's a good first question. Can anybody speak to that? What percentage of vision impairments might be caused by genetics? I have no idea.
I'm wondering if any of my colleagues here have a better answer than me, but that's a really good question, and I think a complex question. What I typically talk about with my patients is when we do know that somebody's been diagnosed with some sort of inherited retinal dystrophy that can be made, a diagnosis made by an ophthalmologist. We say that genetic testing right now has about a 56 to 76% yield or chance that we'll find something in the DNA that explains their inherited retinal dystrophy. So I know that's not a big population-based answer of how much, vision loss might be attributable to genetics, but kind of one of our statistics that I like to talk about with my patients.
Okay, so 50 to 60, you said 50 to 60%? Did I get that
56
right?
to 76. So right in
56
the
to
middle there,
76.
yeah,
Okay.
66% approximately. So right in the middle
And does that mean that for the remainder, I'm trying to understand the statistic. Does that mean that the remainder are still diagnosed with an inherited condition? We just can't identify the gene? Is that right?
That's typically what we talk about in conjunction or with our ophthalmologists. So if the ophthalmologist still says, yes, this is an inherited retinal dystrophy, then we can talk to our patients about, yeah, genetic testing isn't perfect yet. We're still discovering more
Mm,
genes and more, variation within our DNA that we just don't understand yet that might be explanatory in the future that we just don't have the answers yet.
okay, got it. Well, that was I didn't mean to throw a quiz at you right at the beginning. So thanks for putting up with that. Why don't we start or move into a more fundamental question that I think a lot of people may be asking. What is the role of a genetic counselor? What do the three of you do for a living? Yeah, help me understand how you interface with patients.
One of the ways that I like to explain it to patients is that my role is to first help them fully understand what the provider or the doctor has already told them. Often there's some limitations in the time that they have to explain uh, the diagnosis to the patient. And so hopefully breaking that down to an understandable level. And then with that, explaining how genetics has played a role in that being developed. I explain the benefits and limitations of genetic testing. Um, I see it in some ways myself as a living, walking consent form to make sure that they understand this is not going to often be a perfect solution or a cure. There can be ambiguities in this type of testing, and it might come back negative even if we suspect this is genetic, just like Taylor is describing. Um, I gather family history information to give us context of if there's other genes we should be looking at more closely. And then when all of that's done and we send the test off and result come back, explaining those results, helping them get connected with the treatments and or research opportunities that are available, helping them communicate with their family members about what those results mean for family members as well.
Okay, so you're part of the genetic aspect of the diagnostic process and understanding that diagnosis. And when I was diagnosed with my condition, which is Stargardt's, it was in the 80s, so there was no genetic testing. And it was described to me that we've moved from that, what I received as a kid, which was, I think, described as a clinical diagnosis based purely, as you're nodding your heads for those people who can't who are listening on audio. So a clinical diagnosis is based on symptoms in the office and tests, but the genetic is more confirmatory um, based on the genome and much more and sort of lab tests as opposed to a clinical test. What is the value or the advantage for a patient to receive a genetic diagnosis over a clinical diagnosis?
I think it sometimes for some individuals can add some specificity to the diagnosis. So when we know what gene, when we know what specific change within a gene, sometimes we can look in the literature and get some more information on prognosis. Do we, have a little bit more information from other people that have gone through similar things about what we might expect in the future? It can also give us a little bit more information on if there's other, health symptoms outside of the eyes that we might want to screen for or manage. So kind of giving a more holistic approach to some of these conditions that we work with.
Okay. So more specificity, less ambiguity,
Right.
and it might inform prognosis and I guess in some cases even treatment.
hmm
Um, okay, that's great. What
Uh,
what else should I know about your role, or what do we know? What have I imagine it's because it has the word counselor in it. I'm intrigued as a therapist because that's the word we use too. And this is not, as I take it from reading about this, this isn't just hard science. What you're doing, this has a human aspect as well. Can you talk about that? Maybe Emily.
Yeah, so I guess I see myself or our role as part of the care team, kind of as Rebecca and Taylor mentioned, right? We're really helping break down the scientific information or clinical diagnosis for patients, and then walking them through what that diagnosis means, right? What potential implications could be for passing this on. But working towards getting a genetic diagnosis could help provide that more specific information. that's a lot of very technical, right? But there's emotion behind each one of those conversations. So it's also, and I think about that really, it's a conversation with patients of understanding where they're at in their diagnostic journey. How can we best support them in understanding, in their understanding of their diagnosis, and what is the most helpful next step? And maybe that is genetics, and maybe it's not, right? Maybe there's some other way for us to be helpful, and at some point we'll come back to genetic or genetic testing.
Okay, so what are the non-genetic topics that you find yourself spending time on? What are the common themes that you notice that kind of intersect with your work outside of the technical?
In my clinic, the workflow that patients follow is that they will first have a family history call with myself where we gather family history information. And then they have all their testing and diagnostic imaging. And then they see the provider. And right after they see the provider, I come into the room and have my genetic counseling visit with them. And so I see the non-technical aspects coming into the last portion the most, where I get to have a moment, even before I talk about genetics, to check in and say, hey, you just had a discussion about some pretty heavy topics. What are your takeaways from that? Let's debrief that together and kind of chew on it a little bit. Giving patients time to process before they just get dumped out into the world and have to sit there with those emotions by themselves, I find is really beneficial. Um, and then I also see myself as a liaison between the physician that gave them that diagnosis and other resources like social work or vision rehabilitation or low vision clinics and resources. And most of the time, these patients are hearing this information for the first time, and they are still very new to knowing about what resources exist. And so often that day is not the time to just dump them with everything that exists out there, but letting them know that they have these team members behind them. And as we go throughout this process, we're going to be reaching out to them. We're a continual resource and knowing what to expect down the road as far as opportunities to, even if there's a treatment available, what are some ways that they can get involved with peer support groups or connect with other patients that have similar diagnoses, connect with someone that's had this diagnosis for a long time and could explain their journey throughout that process.
Mm.
Or, knowing about what's the process to get a guide dog. Those questions are often the topics I'm talking about, separate from genetics.
It really sounds like what you're describing is you're almost a front door to the community of low vision, whereas the physician might be the door itself, right? Like a little before you're into the community at all, the physician is saying, "Well, this is just here's the fact, and you're now you're on your way," and they don't have, I guess, the time and that to do what you do. And that's really been a theme I'd love to dive into a little bit because I've noticed with my clients and hearing from the community outside of my clients, one of the things that I'd love to see change in this world of low vision is the number of people who receive a diagnosis and then feel like they are all alone. And that's so traumatic. I was fortunate to be young with a very supportive family, but that's not the case for everyone. And it sounds like your role as genetic counselor is a big step in the right direction to have a very friendly, very compassionate face come in the room immediately and say, okay, now let's unpack, let's process, let's make sure you know you're not alone. Is that when you got into genetic counseling, did you realize that that was going to be such an important aspect of what you were doing?
I'll say I love that analogy that you brought up of the kind of the doorway to some of the resources. I really like that. For myself, a personal experience, I feel like I was aware that genetic counselors got that extra gift of time with patients, and part of the
Mhm.
reason that I took interest in this particular career We are across specialties granted a lot of time. Sometimes 30 minutes is, sometimes 20, but oftentimes 60 minutes with our patients. And so we do really get that opportunity to spend time on those personal needs and personal subjects with patients, which is part of the reason that personally drew me to this career.
What about the other two of you? What drew you to it?
Um, I I always had an interest in genetics, and I kind of found the career during my undergrad. And what really drew me to it was that it brought together um, this technical aspect of understanding genetics or science and people, right? That being able to have conversations and discussions with patients and provide them that support. Um, and while you're taught that and get that experience, I think within school, I think once you're getting out there and practicing, you get those real world experiences that you really start to understand the counseling part of genetic counseling. Um, at least that's had been was my experience.
And what I'll add to that is specifically for ophthalmology, I was really drawn by the fact that we have a lot of research going on. Many patients are coming to us having read about research studies, having read about clinical trials, and they are hopeful and wanting to understand. And it was a really wonderful opportunity for me to bring what I have in my science background and ability to understand the research and a chance to meet with that person in that moment that's really tough and provide them actual context and information that can help in that moment. It felt like this perfect joining of being in the right place at the right time with the right information that genetic counseling facilitated very nicely.
That's lovely. I'm curious. Is there anybody who, and I don't want to put you on the spot, and I'm certainly not trying to disparage anybody out there, but it seems like you're only going to have the opportunity to walk in the room for somebody with a genetic diagnosis. Is there anybody performing this role for folks that have received a traumatic brain injury or some other condition that's non-genetic? Because that I ask the question because it breaks my heart when I talk to people and they do feel so alone, and that's really honestly probably the single biggest reason why I started this podcast was to try and alleviate that sense of isolation. So, do you have any thoughts on that? Like, is your role limited to just people with genetic diagnoses? Are there other people doing it for other patients?
I am aware, so this is specific to Mass Eye where I'm located, that we do have access to and colleagues within psychology and psychiatry department who are interested in working and supporting patients who've experienced vision loss.
Yeah.
Um, and so they are amazing partners in helping at least from the genetics clinic, right? Be able to help support patients who need some additional supports beyond what myself and my colleagues are able to provide. Um, but that is absolutely unique, I think,
Mm,
to our institution. I don't know how that translates into other spaces. So I think we're very privileged to be able to have that and offer that to patients.
gotcha. Well, maybe we could shine a light on the need
Yeah.
for physicians, and it's not just vision loss; it's any life-changing diagnosis. That's extremely difficult for people to hear. So yeah, I hope we can, as a culture, get better at supporting people in those initial moments of shock. Uh, uh, Taylor, you mentioned, I think it was Taylor that you mentioned your role in clinical trials, and that kind of prompted a question. So far, we've talked about your role in that initial moment of diagnosis on day one. Um, what is the role of genetic counselors going forward? Do you maintain a relationship with patients over time?
Really, really great question. And I think it might be location specific and kind of what support team members that all of us as genetic counselors have. So I can speak to my team. Um, As far as clinical trials, I actually have a clinical care coordinator that I work really closely with that helps me get patients enrolled in clinical trials if they're interested. Um, but kind of to answer the second part of your question of what does care look like for patients ongoing, I'm really lucky in my role that I get to go into clinic with my ophthalmologist and see my patients again and again and again after for their follow-up visits. So um, there's a lot of opportunity to hear something once at our initial, result disclosure of their genetic test, and then maybe in 6 months when they come for their checkup with the physician, hear a little bit more, or maybe their family planning, thoughts have changed, and so they get to hear more information about that where they didn't want to hear it before. Again, I think that's specific to different specialties in genetic counseling, but I think most of us in ophthalmology are pretty plugged in with our patients in that aspect of kind of this continued care that we get to provide.
That's fantastic. I love seeing and hearing about the relationship that gets to grow over time, and appreciating that the initial moment is not always the right moment for every conversation. And sometimes it's the same conversation might need to happen multiple times. If
Hmm.
we're in shock and just distraught, that's a tough place to be, to receive a bunch of, gonna be inundated with a bunch of technical information. I
Mhm.
think it's most important in most cases, just to feel like you're not alone. So thanks for being the face in the room that serves that role, first and foremost. What is your role in terms of helping people find clinical trials? Is that something you do?
Again, we probably all three have a different answer to that, but maybe in general, definitely for us in our roles, is working with patients to help identify clinical trials or supporting our clinical trial team and coordinator within our institution to help recruit patients as well. So,
Does that include, I say this as I'm reaching out to a clinical trial right now for myself. Does your role include understanding and making informed decisions about the costs and the potential costs and benefits of clinical trials, and helping make what can be a pretty difficult decision?
so I can say I don't, but I actually say that exactly to patients. When we think about clinical trials, right, they're really human experiments. And so this cost benefit analysis is going to be different for every single person, but something they're going to have to consider. So kind of, I think when I introduce the topic of clinical trials or the potential for clinical trials, it's starting those conversations of this may be available. These are what clinical trials are in general, introducing the topic, um, and hopefully laying the groundwork for more specific conversations with the coordinator or physician.
Got it.
Yes. In our clinic, I would say we have a similar role that when we're talking with the patients, we're giving generally much more basic information of just concepts that what a clinical trial is, what are some variables to think about when you're considering. And often I give patients a heads up of once I have a result, hey, this is where clinical trials are at for that specific gene, or these are the areas that are working on research. But on the backside, when a clinical trial is being run at our site, I usually am in the first phase of screening patients. So we have a database where we have all of the genetic test results. And if a or a pharmaceutical company comes and says, hey, we want to do a trial related to ABCA4, and we need all the patients that have variants within this specific region, I do that poll and look through, make sure they have all the genetic testing on file that's necessary, make sure we have sometimes family member testing is required, see if we have everything required there. And then I give that list to our clinical trial coordinators who screen through those patients for the rest of the qualifying requirements, things like visual acuity windows and visual field requirements. If they have any past surgeries or medications, that list can be pretty long. So they do that. And we just had a recent training with our clinical trial coordinator team about how to have these conversations while they're either consenting or while they are in the process of the clinical trial, how to have those hard conversations about, what might this look like if it doesn't go well? What might it look like if it does go well? What support systems do you have? And really engaging in that in a psychosocial manner to make sure the patient's making an informed decision.
It's great to hear. What is, you're talking about making it informed, well, let me back up. We started with something happening to a person, right? That they had no control over, the diagnosis. Now we're talking about making a decision, something they do have control over. And I noticed just how neat it is to be able to move from one to the other. Because that's kind of one of the things I like to do with my clients is move from a place of disempowerment to empowerment. Um, and you also talked about support systems, which I think is also super important. Speaking of support systems, what is your role with family and talking with family about diagnoses and living with conditions?
The most interaction that I have with families is actually often for someone that's interested in clinical trials. And we need family member testing to confirm the arrangement of their variants. And so I will have separate phone calls with either parents or adult children, and trying to explain the background behind this family member's or this our patient's genetic condition and why we would want family member testing. And that's the primary areas where I work with them. The other times that I work with family members are if we get a genetic test result that's inconclusive or uncertain, but we are suspicious that it might be related to the condition. Family member testing can be beneficial in determining that and reanalyzing that specific variant. And so I spend a lot of time on the phone with family members to try and explain how that might impact the patient's understanding of their condition, how that might impact potential enrollment for clinical trials. There are rare occasions also where we end up meeting with family members who say, hey, my cousin had this tested and I have symptoms. I want to. Usually I recommend those go to a local ophthalmologist themselves so that they can get their own personal information for their specific eyes and symptoms. But at least I do give them some basic information about the genetic test itself.
Right. But in that case, they would need to become their own patient at that point. Yeah.
Yes.
And echoing everything Rebecca said, and I think that family is such an integral thing to a lot of what we do. Just having, we're performing testing for these hereditary conditions that, have potential risks for family members. And so I would say almost all conversations that we have with patients regarding testing results, as well as pre-test counseling, talking to them about what testing might mean for family members is actually a big part of a lot of our conversations. A lot of people come to us saying, what are the chances that I pass this on to my kid? That's my main reason that I want to do testing. So a lot of conversations can sometimes revolve around those types of that type of information that we might gather.
That's definitely one of the areas I wanted to talk about today. So since you opened the door to it, let's dive into that a little bit. What is your role and what do you try to convey to patients that are concerned about passing on a diagnosis to either the kids they've already got that maybe they haven't tested or there's no symptoms, or kids that they may decide to have in the future?
I'll say that's a really, really complex question, and I think it's very patient dependent. It's dependent on the person in front of us, on kind of how that conversation goes and what information that they're really after. To kind of talk to, you said the front part of your question was related to like how patients might respond to that information. Is that what you were asking?
That's a great question. Let's go with it.
Okay. Yeah. And I would again say that's very, very, very patient dependent. You know, some potential themes that I've seen in my clinic that I've talked about with patients is, hey, if we do get test results back that are informative for your diagnosis, we can have a more solid conversation about what risks might be for kids. or other family members. And sometimes that information or that knowledge can sometimes be comforting for patients, or sometimes it could be the opposite side of the spectrum where it creates more anxiety because it's a higher risk than they anticipated. So kind of talking with patients about, you know, is this dominant 50% risk? Does that feel high to you? Does it feel low to you? And kind of getting a good grasp on
Sure.
where they're feeling with their potential risks for family members is some of the conversations that we'll potentially have even before testing when we're deciding if testing is a right step for those patients.
It occurs to
Yeah.
me that you all are at at a in a room where you're having conversations where the reality that statistics devolve into meaninglessness down to when you get to a sample of one, right? Like they're only useful at larger scales, and you're dealing at the literal one human level. I think in our culture, in our society, we don't understand that very well. I think that's why we don't have a lot of data literacy in that sense. And that throws us off a lot. It can be very off-putting when we think about probabilities as something that you can sink your teeth into when in fact it's not. Is that something you talk about and help people work their way through to say that your experience is your experience regardless of what the statistics might say? Emily, you're
Yeah,
nodding
I
your
think
head.
yeah, I think it's very much validating where the person's at, right? So there's the fact, right? It's 1 in 4 or 1 in 2. But how person A understands and feels and perceives 1 in 50 or 1 in 2 or 50% is very different from the next person that walks in the door. And
Right.
so I it's I guess for me really having that like here's the number, right? How do you feel about that? What does this mean to you? And kind of talking about it in many different ways, like
Great.
um, in terms of, is it 1 in 2 or 50%? Those may elicit two very different responses. Um,
Yeah.
so kind of understand, like, can we, provide information in multiple different ways that's helpful to kind of get people to kind of understand where they're at.
Yeah.
So
I like to remind myself. I love the reframing because reframing is a big part of my job. And when I think if something has a 1% chance of happening, I think most people would think that that's minuscule. I don't have to worry about that. That's not a big deal. But if I tell you that if you have a 1% chance of something happening every day this year, it's going to happen more than 3 times. Like that's every couple of months, every few months. That starts to feel very, very different, but it's the exact same statistic. So I love how you're trying to help people see it from multiple angles. Um, does this ever show up with having partners tested in order to determine the likelihood of heritability of a condition?
Yes, it certainly does. We get those questions a lot. And I think each clinic handles it slightly different, whether they would recommend going to prenatal genetic counselors for that or whether we can do the testing ourselves. I'm at an ophthalmology genetic counseling clinic. But um, one thing I was going to bring up with our previous conversation and also applies here is that a challenge with ophthalmology genetics is that many of these genes present uniquely and differently in each patient. And so with these statistics, we have to continue adding some some ambiguity in with that. And for example, if I'm counseling a family about ABCA4, which is associated with Stargardt's disease, like you've experienced, Matthew, I we can look at the specific variants in that gene and give some guidance as to what a patient might experience, but it's really challenging to tell two parents and say, hey, yes, you may be experiencing this, but we actually can't guarantee or really know what any offspring with these same genetic variants might experience. And so trying to counsel them through that ambiguity takes a lot of time and I think attention to the gray area.
Yeah, is I want to. introduce a couple technical terms and have you all define it, because I think what you're talking about here, and this is not my area of expertise, is the difference between genotype and phenotype. Am I getting that right? And could somebody unpack that a little more so people can understand it?
I would typically describe genotype as somebody's, present genetic variants that we can identify on testing, and phenotype would really be those clinical features that the ophthalmologists that we work with are identifying on exam. Um, so sometimes a genotype can present with different phenotypes or different clinical features, and so that's why we really go through the literature and see what cases have been published before to kind of get that spectrum of where we think patients could potentially fall within, whether that's no symptoms at all, even if they have the same genotype, or if there's maybe a smaller focus spectrum for specific genotypes. And we think, hey, most people experience this. So it does get really complex, echoing Rebecca, trying to kind of identify what a patient or a family might experience. And it really goes back to making sure we're continuing research efforts and things like that to better have information for our patients in the future.
So that's why it's complex enough to make a decision about passing a condition, potentially passing a condition on to a child if it was just that. But because I think if I'm hearing you right, because any given genotype can express itself in different ways in the phenotype, it makes it that much more complicated. Yes, you may pass along the condition, but it may look completely different than what the parent is dealing with. So it is a huge amount of uncertainty at that point. And I guess, and the amount of uncertainty I would assume would depend somewhat on the diagnosis. So I would imagine certain conditions would have broader possibilities and other conditions would be more narrow. I think that's what you were alluding to, if I was understanding it right.
Absolutely, yes.
Okay.
You understood that well. Well done. Those are complex topics. You picked it up fast.
um, that makes me think that you all are not just doing individual counseling. You're doing couples counseling and family counseling in a lot of cases. That's a lot. How do you receive this work yourself? I mean, you're in the room with people on potentially one of the worst days of their life, and that happens all the time. How is that for you?
Some days are harder than others. Giving bad news can be hard, even for your providers. But I really see myself there as being the person to help support and provide that information in a way that is not adding to any trauma. Like, we're here to help support, right? So, and I think it's a lot of the times I do acknowledge it to my patients. I was like, this is really hard. And I think that I find it can be helpful sometimes to acknowledge that.
When I meet with patients that are usually in their first experience with this diagnosis, those are obviously the most heavy conversations. And personally, I spend a lot of time on the back end beating myself up or saying, I should have done this to better support them or help them through that situation. There's always kind of a consistent after talk and also just kind of mourning for them in their situation. But overarching, that's actually quite small compared to the other emotions that I experience in this position. Because of the longevity that we get to see patients through year to year and we get to interact with their families, one of the wonderful things about my job is seeing that patient had such a hard situation that they were in the first time we met a year later and see how they have grown emotionally and set themselves up for success and see how they found joy and independence in certain areas of their life despite these vision limitations, and seeing patients all along that spectrum and seeing the progression over time is really hopeful for me. And I think, to second what Emily was saying, that's what I try and reiterate to patients in that first session. Whether I do that perfectly or not, debatable, but overall, that hopeful trajectory is something I take away from this job.
I'm really grateful for both of your answers. One of them really makes clear that the entire care team is human too. And that I think is important for all of us to bear in mind as we go through difficult things. Um, and then I also really love the message of hope that you offered, that your worst day will be just that, probably your worst day. Not to say there won't be bad days and hard days. I think I'm a big believer in emotional honesty, but I'm also a big believer that we get better. We have the potential to get better and heal emotionally, even if our eyes can't. And to your point, Emily, about not adding to trauma, I've come to believe and understand in the job I'm in that having support when you're under threat, and a vision diagnosis like we're talking about is definitely a threat. But having support is the thing that prevents trauma. I don't think it's not just, I don't think it's a matter of not adding to trauma. I think you're actively, I think if your job is done right, and it seems like it is for in your 3 cases, if your job is done right, you're actively preventing trauma, which is why I am so grateful for the work you're doing, and I wish there were so many more of you for people who are receiving these diagnoses and don't have that support and feel so isolated. Just that is where the trauma gets born. Um, before we wrap up, I want to ask what else you wish people knew about what you do. What do you want this audience to know about genetic counseling? Maybe perhaps any misconceptions that you hear a lot that you'd like to address, myths you'd like to dispel, really anything you want to share with an audience.
One of the most common misconceptions I run into with patients is they see genetic testing as a black or white yes or no. And I think clarifying and helping patients understand that genetic testing is truly just looking at the spelling of their specific genes. And usually it's only a subset of your genes. And we are being very intentional about picking those specific genes to look at. We're reading through them, comparing it to a standard sequence of someone who doesn't have those vision changes. And as they're noting differences, they are basing their interpretation on research. And sometimes we don't have research based on that specific spelling change. Sometimes the research we have is limited. And so it really is more of an art in interpreting and understanding this. And as we learn more, those genetic interpretations improve. And so I think my, big message to individuals who are new to genetics or trying to understand is to keep that in mind, that there's ambiguity here. We're relying on research. And so with that in mind, there can be uncertainty.
Is that a reason you would encourage people to do the genetic testing, even if they don't have a specific reason that serves themselves? Like, for instance, I know my genetic information is in my Retina Tracker, which is a program of the Foundation Fighting Blindness. Is compiling those large databases useful for you all to be able to interpret the genetic results you get back for any one person?
That's a two-edged sword. I mean, theoretically, yes. Obviously, the more data, the better. But I would not say that value outweighs someone's desire for privacy or, desire to. Everyone can have their own reasons to pursue or not to pursue genetic testing, and I don't think those need to be strongly swayed just by saying, "Oh, we have to build our research database." That it should all be part of the discussion.
Right. I appreciate that focus on autonomy there. That's great. What about the other two of you? What else would you like for the audience to know?
Yeah. First of all, I just want to thank you for having us as guests, because I think my big takeaway is that we're here. Genetic counselors are here. And I think because of accessibility to genetic testing for ocular conditions has um, become increasingly available across different institutions and different practices. Genetic testing uptake has increased, and genetic counselors are there to help everybody kind of walk through those results and what they mean for you, what they mean for your family, and spend potentially some extra time with you discussing those types of things. So there's not a lot of us out in the genetic counseling space. I think we're only 1% of the full genetic counseling workforce that actually specializes in ophthalmic genetics or ocular genetics. So we may be few and far between, but we're here. And if you have any contacts to be able to get in reach with one of us, feel free to try and see what you can learn from us.
Yeah, that you raise a good point, and boy, what a blessing it is to have three of you when there are so few of people, these people doing this work. So thank you for being here, and thank you for your kind words. For somebody who is getting diagnosed at a smaller clinic and they don't have genetic counseling available to them, what are their options for getting help from somebody who does what you do?
So one of the resources that sometimes I'll talk about with patients is we have a national society, the National Society of Genetic Counselors, and they have a web page that you can try to identify genetic counselors in your state and specifically pick the specialty you're interested in. So if that's ophthalmic genetics or ocular genetics, you should be able to select that on there too. That's typically what I'll turn patients to. I will say one of the limitations of just medical care, in the United States is there's, licensure that's needed in states to be able to perform um, our specific duties or our practice. So there are, limitations on state lines on where we can provide patient care. And of course, that creates, barriers for transportation and things like that. Um, but that's typically where I turn patients to for assistance if they're across state lines or need some help finding maybe telehealth in their state.
Okay, thank you for that. I'll try and remember to put the link to that in the show notes if anybody
Yep.
wants to click on that. Emily, do you have any final thoughts?
No, I would definitely echo what Rebecca and Taylor said, and we, as genetic counselors are here as again as part of the care team, right? In places where we can be able to help interpret this complex genetic information for patients, and connect them with the resources and information that they're looking for. As Taylor mentioned, right, we also turn to the National Society of Genetic Counselors, and refer patients there, or even the American College of Medical Genetics to try to get folks at least connected with a medical genetics clinic that could be closer if there's not a genetics clinic, to at least be able to access genetic services. There is a network of us, so it's not just the three of us, right? There is more and more genetic counselors focusing in ophthalmology. And it's a fairly good network in terms of, well, if you're, someone calls from this region of the country, I'm like, I can't practice there, but I know so and so who does. And so it's a nice way to be able to connect patients that way as well.
There's this image in my head right now of somebody listening to this who's received a diagnosis and they don't know what their career is going to be because they may not be able to do what they've always been able to do. And I'm thinking, maybe you could become a genetic counselor.
We'd love
'Cause
that.
yeah,
Yes.
I know
Come
that's
join
that.
us.
Yeah, I come or a mental health counselor too. That's
Mhm.
something that doesn't require perfect vision, and you can make a big difference. So there are careers available to people with vision loss that are incredibly meaningful. And I know that none of the three of you, as far as I'm aware, have your own vision impairment. So that makes it to me extra special that you've devoted your life's work to a community that is oftentimes really feeling scared. And so thank you for being the frontline workers for soothing and easing and educating and empowering folks who are having a really, really difficult season. So thank you for the work you're doing. I really appreciate it. And thank you for being here today.
Thank
Thank
you,
you for having
Matthew.
us.
It's
All
a real
right.
privilege and so exciting to have this resource for patients. I'm already telling some patients about it. I'm really hopeful that this exists.
Today's conversation highlights that genetic counseling is as much about the human heart as it is about hard science. I was particularly moved by the idea of the counselor as a supportive bridge, helping patients process heavy news before they have to turn to the outside world. We learned that while genetics involves complex statistics, your personal experience remains the most important factor in your journey. Ultimately, these specialists remind us that even when we don't have the capacity to heal our eyes, we have an incredible capacity to heal and thrive emotionally. It's a powerful reminder that support is the primary antidote to trauma. Thanks for joining us for this episode of Insight Out. You're the reason this podcast exists, and we'd love to hear from you. You can leave us a voice message at speakpipe.com/insideoutpod. That's speakpipe.com/insightoutpod. INSIGHTOUTPOD. There, you can share your thoughts about today's conversation, suggest a topic for a future episode, or tell us about your experience living with vision loss. Again, that's speakpipe.com/insightoutpod. Insight Out is produced by Integral Mental Health Services, my private practice that offers psychotherapy for adults in Georgia and disability adjustment and chronic illness counseling nationwide. Visit us at integralmhs.com. And you can visit insightoutpod.com to catch up on all the episodes and to find links for subscribing in all the major podcast apps. A video version of this podcast is available on YouTube. Search for the channel using the handle @InsideOutPod. You can also find us on social media using that same handle. I hope you'll join us for the next episode of Insight Out. Subscribe now in your favorite podcast app to stay connected. Thanks again for listening.